Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Okay, we're going to talk about feet. And who else would know more about feet than a podiatrist, but a very special podiatrist, Dr. Neil Strauss. So if someone asks you why you became a podiatrist compared to, a brain surgeon, what would your answer be?
I kind of fell into it. I come from Pittsburgh, Pennsylvania, a small town in the Beaver Falls area. And my family, actually, I would have been third-generation shoe store owner. My dad had a Stride Right store, so I think that had something to do with it. But I made my dad a promise that I wouldn't own a business that had inventory. And then I went to college in Dickinson College in Pennsylvania, and then moved to Philadelphia and worked in brain injury for my cousin. And I had a friend from college. The first person I met in freshman year in the dorm put a key in the door. He said, "Hi, I'm Steve." And he ended up going to podiatry school in Philadelphia, but I would hang out with friends while I worked at the brain injury rehab, and ended up just hanging out with them and applying for school, and I got in.
Yeah, and podiatry is a very interesting profession, I think, because as one ages, they can't take care of their feet.
Correct.
And that's unfortunate because many people then can't walk, and they change their whole life. And people don't think about feet. A lot of people don't even want a foot massage. They're embarrassed about their feet.
I'm one of them. Yes.
Really?
Yes, I don't like foot massages.
Oh, my goodness, I love a foot massage. So it's very interesting to talk to a podiatrist and find out one thing that I know there is a question as far as how far up on the leg does your profession allow you to go?
That's actually a constant battle that I fight every day professionally. We used to call podiatry the P word because most people assimilated it to what chiropody was, 50, 60 years ago. It was basically a toenail cutter and took care of corns and calluses and toenails. Fortunately, with the APMA, the American Podiatric Medical Association, and since like the 70s, I would say, especially in South Florida, a lot of key doctors got and lobbied, in a sense, and sued hospitals to actually get hospital privileges. Podiatrists used to not have residency programs. Literally, podiatry students would graduate from school and start operating on patients. And there was a lot of shoddy surgeries back in the day. I mean, honestly, there's a lot of horror stories. They used to do minimal incision surgeries, which are actually, when you get on staff at a hospital, you have to say you won't do minimal incision surgery because that's such poor outcomes. It was barbaric in a sense. What happens now is there is exactly like an MD, which is allopathic medicine, and osteopathic medicine, a DO, formal surgical residencies, which are 3 years specific in a hospital base. And I'm a past director of a 3-year surgical, which is the highest level of residency. Podiatrists today are actually what I like to call the equivalent of a plastic surgeon, a foot and ankle orthopedic surgeon, and a podiatrist all in one. We do everything from basic diabetic foot care, toenail care, corns and calluses, sports medicine like flat feet, heel pain, to foot reconstructions from infants to geriatric patients, amputations, bunions, hammer toes. I have a niche business because I have such a network in the hospitals. I'm the largest, with my partners, the largest podiatry practice in Broward County by coverage in the hospitals, which is very unique. Most MDs and DOs don't even consider me a podiatrist. I just have the degree because I am intertwined with them and interconnected in a multi-specialty approach to treating patients. So I believe in continuity of care. And when I first started 12 years ago, I found that there was a discontinuity in care because most quote-unquote podiatrists would say, "Oh, you have a foot infection, go to the hospital," and the patient has to meet a new doctor, new nurses, new care, and the paperwork from the doctor's office typically didn't make it to the hospital. So there's a lot of repetitious, non-cost efficient medical care and a lot of redundancy. So I was fortunate enough to see that from a business perspective and care perspective. And I said, why not go to the hospitals? Why not? I hate changing my barber. I hate changing my dentist. I use the same guy to wash my car. I mean, I'm a creature of habit.
I am too. I like that.
And I don't like change. So I said, why don't I treat the patient in the hospital? So that's what I did. And I treat the patient from my office to the hospital to the nursing home back to home. I follow my patients like the IRS. I really do.
Like the IRS. Well, that gives me, it's a lot of brownie points for you because you're so right. As a gerontologist, I always say it's the trauma that can kill people, not the, not the actual effect. It's people are taken, from their home to the hospital to the nursing home, and people don't understand what that's like. And so to have to list the same doctor,
the right hand doesn't know what the left hand's doing.
That's right. But also because they know you, and and knowing your personality now, probably they make you you're their friend, and you help them suggest other things.
I befriend my patients. I actually do. I
can tell.
I'm known in the community to give everybody my cell phone. My wife knows, and my kids know that I perpetually work. I don't have a 9-to-5 job. I think this is being a medical professional, especially in the hospital-based industry. It's a life. It's not a career. There are many times that I'm at dinner with family and friends, and I have to take a call. It's just the way it is.
I thought you were going to say they take off their shoes to show you their feet.
No, that's actually banned. I check their insurance first.
No, because it's funny. I have a friend who's an OBGYN. It's like they always want to talk about these aspects of something. So, okay, well, I want to get back to something that probably maybe it's not as important, but there's been a whole revolution in shoes.
Yes.
From tennis shoes to flip-flops to formal shoes. Do you actually help people choose the shoes that they should have?
I don't influence them, but I advise them. I always ask my patients to bring in the shoes that they wear and to see if they're wearing the right shoes for them. I grew up in the shoe business, so I actually know a lot about shoes. I mean, my dad, one of his closest friends in business, is actually a very, very powerful person in a very large sneaker company that everybody knows. It's 4 letters. And the evolution of shoes since they started in the 70s, like tennis shoes really came out, like the Nike Cortez was like one of the first running shoes that came out. They were just a basic rubber sole shoe with really no ergonomics in the shoe. Nowadays, they're so technical with anti-pronation devices, anti-supination devices, arch supports. I mean, there's a whole business just in orthotics now. And there's a lot of, you could go into the mall and you step on this special pad that shows pressure points and everything. And really, in my opinion, is good for patients, but I don't think it's really an over-the-counter type product. I think there's a lot of, even though you're stepping on a pad, there's gait analysis, which is walking. I worked in Philadelphia during the summer when I was in podiatry school in a gait lab where they actually put little ping pong balls on patients and they check it with pressure pads, and it's looking at like a computer and how people walk. You're not getting that just by stepping on a pad. So I always tell patients is if you buy it at a store, don't wear it. Bring it to me, and it's because I want to make sure you can return it if it's not right for you.
That's great. That's the biggest problem. I'm really glad you hit on it because people just go out willy-nilly. They buy shoes, all kinds, and they're not right. Then they buy another pair, and then they go to the stores, the diabetic stores. Yes. Because the diabetic stores have certain kinds of, what do you want to say?
Products.
Yeah, right, because they're all different. And they think that that's the answer. That's still not the answer. But the people there sometimes know about diabetic shoes, but sometimes they're not. They're just, salesmen that have just happened to work there. So,
well, nothing against them, and they do know their products, but the question is, do they know the biomechanics behind
that's right.
Each foot and the foot types and what causes it? I mean, it could be a muscle imbalance. I mean, a patient could have MS and don't even know it yet. There's so many factors that go involved, and I'm not a big fan of over-the-counter products. I think it's wasteful of money, and I think it's it kind of makes, I would say, podiatry look bad in a sense because a lot of patients will buy them and say, well, you told me this doesn't help. I'm like, well, you bought it on your own accord. You didn't ask my opinion on it, and you just self-diagnose yourself. Like a lot of friends go on websites and start self-diagnosing like they went to medical school. And I always say, until that website has a medical school, talk to the professional.
Yeah, you're right. Dr. Neil Strauss, Strauss. He is let's see. We have to call you more than a podiatrist. What is the proper word for you?
I would say, you asked earlier about the delineation of what a podiatrist can treat. At the end of the day, I'm a podiatrist. My degree is in Doctor of Podiatric Medicine, but I call myself a foot and ankle surgeon. and also a wound care specialist. I'm the only one in Broward County that has I'm quad board certified. And my partner, Richard Breitstein, we're quad board certified. So what happens is we're a specialty within a specialty. I have a niche business. I really do. And that also, being diverse, helps my patients. And I'm the first doctor. If I don't know, I'm going to send you to somebody who does know. I think that's being a good doctor, is knowing your limitations. And fortunately, I have 4 doctors in my group. And so there's like 4 internal opinions. And we always don't agree. I mean, I think you have to do what's right for the patient, not what's right for ego.
And so are you finding, because everyone's into sports, that there's a whole new field now of sports medicine for podiatrists?
I think sports medicine's always been a big specialty, but I think what's happening now is there's a lot of high impact with CrossFit, these mud runs. Patients are really exercising themselves beyond the body's capabilities, in a sense. There's a lot of, I don't want to call it disfigurement, but CrossFit, if you look at females, it's really taken away from the femininity of a woman. It's becoming very bulky, and they're really pushing themselves to stress fractures and tendon strains and sprains, and it's like boot camp. I mean, it's really what it is. I mean, it's very fast-paced, heavy lifting, and it's dangerous. If patients can get hurt. I mean, I know of a patient who had kidney issues because of working out too much. Developed rhabdo. I mean, it's really not good. Lactic acid buildup.
Yeah. So see, that's why I think that your position and what you're talking about is someone would just go to you and say, okay, I need exercise. I need certain kind of shoes. I have when I get up in the morning, my feet tingle. Mm-hmm. And then you would give them a complete analysis, I would assume.
Absolutely. I think the most important is your spine and your feet, because a lot of foot tingling comes from lower backs, patients not lifting correctly. A lot of patients bend over to pick up. You should always bend your knees and lift up straight. I'm a spinal patient. I had spinal surgery, so I was a victim of text messenger, sitting at a stoplight. So I'm a patient as well. So I get it. I know what it's like to have to go to doctor's appointments and the stress of surgery, going under anesthesia. I can tell you I had my surgery at Broward Health. I'm a patient there.
Right, so you understand what...
Yeah,
well, that's good. And I'm sorry that happened to you, but...
Fortunately, I had a wonderful surgeon who I ultimately respect. I mean, he had me back to work in 11 days after having a fragmented disc. But my pinky toe on my right foot still tingles. I live with it. So it's when a patient tells me, my pinky toe tingles, and if a person who doesn't have surgery may not have empathy for that patient, right. I get it. I know what it's like. I had a talk with myself saying I might not be able to walk without a brace if I didn't have surgery. So I've had that talk. I've had that realization of what it's like to be on the other side.
Wow, that really does say a lot, and that's why patients probably are enjoying you, because you do have a lot of empathy. I can feel it in your voice and all. Okay, so Dr. Strauss, as one grows older, should they go every month and have their feet checked and have their nails taken care of and see if there's anything going on? Is that something like people would go and they go to their family? What do you recommend for that?
I think 3 months is probably appropriate, unless they have a comorbidity like diabetes or, if they have an inability to cut their toenails, then, I think Medicare calls it 62.5 days is a good judgment, unless there's a risk of infection or other things. A lot of my patients who are diabetics, they're like, I can only see you every, 10 weeks. I always say that's for a diabetic foot care. However, if you have an infection, come in now. I always like to say is I'd rather you come in and waste your time and find out it's nothing than to you not call me and lose your leg. So, it's a reality with life. Diabetes is horrible. Absolutely horrible.
Yeah, it really is. And it seems like it's just taking on such great proportions now into what's going on. But I think that what you've said has been very helpful for a lot of people to see that they shouldn't just decide on a shoe themselves, especially, and whether they're young or old, they could be a millennial as well as, an elder person. Because when you think about it, sure, your spine is very important, but you get up, and what's the first thing that hits the floor? Not your spine, but your feet, right?
Absolutely.
It's part of your spine, but your feet. And so I don't think people take very good care of their feet, do you?
No, they neglect them, especially the bottoms of their feet. I always, diabetics, we always say you need to check the bottom of your feet at breakfast and bed. And so when you get up, and they used to make, and I wish I could find a company that make them now, but one of the drug companies used to dispense them as, advertisement, and there's a lot of laws now that they can't do advertisements in the office, but they used to have a plexiglass window a mirror that would sit on the floor, and patients could actually see the bottom of their feet. And so I always tell patients, I said, go to like one of these local cheap discount stores. Don't get glass, but find a plexiglass, or go online, get a plexiglass little mirror and put it in the corner of the wall and the ceiling, or the wall and the floor, and look at the bottom of your feet every day. I mean, when I was in school, I was in clinics. I don't know if it was here or Philadelphia, and a patient said he had a pain on the bottom of his foot. So I started debriding the callus, and I was looking at a beer bottle cap that covered over with callus tissue. So daily foot checks are minimal
Wait.
issue.
You're telling me he had actually stepped on a beer bottle cap and this had grown over that?
Mm-hmm.
Unbelievable.
Yes. So I've had patients that have had embedded toothpicks, needles. Nowadays, which is, I don't know how much in Palm Beach how it's happening, but in Broward County, there's a huge surge of IV drug abusers injecting into their feet, especially on the east side, and they're young, and it's really sad.
In their feet?
Yes. It's actually crazy. If you look at other countries, they actually teach drug addicts how to inject, like a phlebotomy class, and they dispense clean needles to make sure they're not transmitting hepatitis C. I mean, I have patients who are 20 years old who have hep C, major drug abuse, in sex slavery, and could lose their foot, and it's scary. And there's a lot of frequent flyers. They're injecting medications like oxycodone, Roxy's, heroin. It's really sad.
I saw a whole documentary in China. That's where a lot of these cheap things are coming from.
Well, Flocka, I believe.
No, but something else now, a new thing.
Flocka was really big, like last year and the year before. Actually, I think at your hospital, I think someone drove into the emergency room. Literally drove into the emergency room. I saw a picture of it. The car was sitting at the secretary's station.
Yeah, I know. It was horrible. Was there something else too? But let's just get back to this. So on a normal day in your office, what would your patients look like? I don't mean visually, but what would you be seeing them for?
Fortunately, I have a diverse practice. Every day, I see a lot of wound care. I have a lot of wound care patients. Wound care patients are like family to me. They know my children. They know my wife. They know everybody because we see them on a weekly basis minimally. So they become like family. We know if they're late, we worry, we call them, and because they're very punctual typically. And we send in work with home health care companies in the community. So we always have an eye on them. So that's a large percentage of my patients. There's heel pain's very big. I work with the cruise ship companies, and their cruise ship employees work very long hours. So I work with Broward Health. They have an international program. And because the Port Everglades, a lot of the cruise ship employees, when they come to port, they see doctors. And our goal is to get them safely back to work. Otherwise, they have to go back to their country of origin. So I treat a lot of heel pain, sprains. I take emergency room call at 3 emergency rooms. So I do foot and ankle fractures. I see it all. I mean, it's very diverse. I would say 60% of my practice is wound care, and the 40% is heel pain, elective work, diabetic foot care, elective work meaning bunions and hammer toes, and then a lot of my post-operative patients, because our group, we're at so many hospitals, when we operate, whether we're doing fracture care, infections, amputations, whatever it be, skin grafting, those patients need to follow up once they're discharged, so we see those as well.
And the amputations usually would be diabetics, right?
Typically, unless it's traumatic.
Unless
we actually have a great story from Imperial Point. Imperial Point, Broward Health Imperial Point, is actually a very unique district hospital because it has hyperbarics, it has wound care, which I'm on staff at, and I work with wonderful surgeons there and doctors. But it also has interventional radiology, which is phenomenal. The primary doctor there is Linda Hughes.
A very good friend of mine, yes.
Very good friend of mine as well.
Right.
She's, in my opinion, the best in the business.
I agree.
And we work together, multi-specialty approach. So I have a patient, let's say I have a patient that comes to the wound care center, and we call in all of our resources, whether it's infectious disease, nephrology, cardiology, because Dr. Zachariah's group's now there with a new lab. And what we do is we come together to really get that patient healed in a very cost-effective manner. And our goal is to not have the patient have to keep coming back. It's to get the patient optimized, heal them, and move on. But that's like the diabetics. We have a young patient we're actually going to do a story on. I was actually called in as a second opinion. Dr. Arison, Dr. Bermudez are vascular and general surgeons. They were on emergency call, and a young gentleman who does Ironman triathlons, he was swimming in the ocean, stepped on coral, and developed a very horrible, eradicating infection that he almost lost his foot. He came in septic into the hospital, and they took him to emergency debridement, and he was left with half of his big toe and very minimal potential to heal. They did everything they could, and since I work with them, Dr. Bermudez called me, and he's like, I need your opinion on this. And he's like, what would you do? And I said, I have an idea. So we did it, and we actually saved a toe. The toe is 100% healed, and that was a combination of hyperbarics. First, the patient had IV antibiotics and surgical care of the infection, hyperbarics. I debrided it and treated it. It had a fracture as well, and skin grafting, all in one. And it is very unique. Specifically, of all the district hospitals, Imperial Point is the most unique, because on the east side with snowbirds, and now snowbirds, people are retiring at different ages. So you have a very different, I would say, age cohort of retirees. And we see everything. I mean, I've had children at the wound care center, which is not really frequent, but I do see them.
You know, I'm really glad you brought up the fact as close as I am to, and I'm probably closer to that hospital than most of them. I did not know they had hyperbaric oxygen.
They do.
And they use that for everything. That we were just talking about, they're using it now for foot, but they must use it for other kinds of things, for brain.
Yeah, I think one of the first criteria was, I'm not by any means a hyperbarics medical professional, but I'm in the business, if you know. I speak to the specialists. Dr. Monteo, I work with him all the time. He actually oversees it there. And there's a lot of criteria. Patients who've had bone infections that have failed antibiotic therapy. Bone infections called osteomyelitis. And if the typical course, through my experience, has been 42 days of IV antibiotics. And then once they've reached the limit on that, because there's becomes risk versus benefits and effects on the kidneys and everything, that they have to look at different care, and whether it's more debridements. And if the infection or the bone or the wound hasn't healed and all of that previous treatment has failed, then they meet criteria. So a lot of times in the mandible, patients have had bone infections. It's one of the criteria is when they've had bone infections, osteomyelitis of the mandible is actually one of the criteria for it.
Yeah, I'm a very big proponent, actually, of that system. And I know plastic surgeons use this now, a lot of times minimal kind, but to help heal.
Yeah.
But I'm glad that you're such an open person. I like
Thanks.
that. It sounds like you are really an experimenter, quality, but that if something's not working, that you will go and do research into resources, and you sounds like we will get this taken care of, right? We will.
Yeah, I truly believe wound care is such a new subspecialty that I think if you believe in limb salvage, the books aren't always right. The books are old. So there's new books being written, and there's new technology coming out. I mean, everybody's heard of nanoscience. Nobody knows what it is. Nanoscience is we use, in wound care, we use silver. And silver as a natural element is an antibiotic. They break it down into 10 to the negative 9th, into the nano size, microscopically, and it treats 99.9% of infections typically at the time. So that's what the packages say. So there's, you hear of MRSA. MRSA is rampant. Nobody knows what it is. The lay person sees it on the front of, certain newspapers, and they get freaked out by it. When I graduated from residency in 2005, it was like the prevalence, how around is it, was like 30% or something. Let's call it that. Now it's like we consider everything MRSA until proven otherwise. Before it was, it's staph, but let's see if it's MRSA. Now we kind of expect it to be MRSA, and that's because of the resistance to antibiotics. So when you have a natural element like silver that has a more broad spectrum, if you will, than the antibiotics, you kind of lower the resistance to antibiotics. It's kind of cool. And I always say that wound care is like chicken soup. Every family has their own recipe. And I've lectured all over the country, and everybody has their own different recipe, if you will, for wound care. But sticking to the basics, you have to stick to the basics and know your basics to then venture out to the line of the envelope, if you will.
I love it. You're really quite a wonderful guest, Dr. Neil Strauss. I want to give everyone your phone number. So if you're looking for a podiatrist that has personality and a lot of experience, I would certainly recommend him. Phone number to call his office is 954-722-8080, 954-722-8080. Or you can go to wounddoc.com, wounddoc.com. So I see you're really doing a lot of that.
I'm very focused on wounds. I actually just legally changed the name of the practice. It's actually now Advanced Foot, Ankle, and Wound Specialist, PA. I just procured a very large Humana contract for 3 counties. So I just opened an office at Broward General this month, and I'm opening in Dade County and Palm Beach counties so that we can maintain and increase the continuity of care in a cost-efficient manner to patients.
Excellent. I am so really happy to have met you and see that you are really going to make everybody's feet tingle in a good way. And also, I just have to say that when people think about their feet, that they're ugly, let's not think that they're ugly. Let's just think that they're just beautiful and that you want to go. And do you tell people how beautiful their feet are? Maybe you have to start doing that.
I'm a vain person, so I get it. I mean, if we were living in Pennsylvania in the snow and wearing boots, people wouldn't notice. But down here, everything's flip-flops and fun, Right. So it's unfortunately genetics always wins.
Yeah, that is true. And another time you come on, we'll talk about flip-flops. It's not a good thing to do because
especially in the rain.
Yeah, well, people have accidents, so we won't go there now. Thank you, Dr. Strauss. This was absolutely wonderful.
Thank you for having me.